ahead and get things started off. Again, this is being recorded for anyone that if they have to go for some reason, it should be posted to the AOCPM on our website. Um, anyways, my name is Alec Curtis. I am the co-chair for Research Committee with AOCPM&R. I'd like to introduce Tiffany.
Hi, I'm Tiffany Wood. I'm the other co-chair for our committee.
And have the pleasure of hosting the session for Marc, Dr. Larsen-Hallock, and he is going to be presenting a meta-analysis over the efficacy and potential determinants of exercise therapy in knee and hip osteoarthritis. And also with a little bit of a focus on how to read these papers and how to break them down, as a lot of us are just beginning our careers in literature reviews. So I'm looking forward to learning, and I'm excited for the session. So take it away.
All right, perfect. Awesome. And just for you guys that are joining me live, I am on call right now. It's home call, so it's pretty simple. There could be a chance that I get some pages during this period of time. I have a colleague who's going to help me cover them, but I need to tell them which number to call back during this period of time. There's always a potential chance that I have to cover an emergency, which might necessitate me having to table this until another time. But just want to let you guys know that shouldn't happen, knocking on wood, but just so you guys know ahead of time if something does happen. Hopefully everyone that's had a chance to come to this presentation and this journal club tonight would have a chance to look over the article. And for anyone that wants to view this later, I highly encourage you to go ahead and read the article beforehand, because that's kind of how you're going to get the most out of this session tonight. Essentially what my plan was today was to go ahead and kind of walk you through how I look at one of these research articles and what I do to determine, how I critique it, and if I think it's going to be useful, and if it's something I might apply to my practice in the future as well, and something I'll inform my patients of. That being said, I will give you a caveat that I do not claim to be a master statistician, nor do I claim to be a master at critiquing research in general, but I would like to give you my sense of what I do going forward. Just so you guys have it, I have there we go. This is kind of what the picture looks like. I just did a screenshot so it doesn't look the best on here, but this is just so you can pull up the article and you know exactly what you're looking for if you don't already have it. All right, so the first thing we need to talk about before we even look at the article itself is kind of what our steps would be to go through and actually critique the article. And so there's a number of stepwise focus that I'll try to take you through as we go through this article itself. So the first thing, obviously, is what is our study question? Is the study question going to be something that is going to impact our careers, our practice, or something that we need to worry about? So for a lot of us that are viewing this are working towards being a physiatrist or already a physiatrist. And so a lot of these things we want to be focused to that general direction itself. If you have a paper that's looking at the benefits of kidney biopsy for some glomerulonephritidity, it may not be the most beneficial thing to a physiatrist. Anyway, so once you start looking at that, you want to make sure that the question is actually appropriately focused and it's not too broad and not too narrowed down. So that way it's both generalizable to the population, but it's also internally valid at the same time. As you're going through these things as well, we want to make sure that they did not miss important studies. And that can be pretty easy to do when you think about the plethora of data that is out there to be obtained. Not only do we have English papers, but we also have non-English papers in journals that we need to consider. And we also need to consider data that was not published. This will come back again later, but we need to make sure that we include data that may have not been worthy of publication, or at least in the minds of American authors, which we, especially with English journals, only publish data that was positive in nature and nothing that shows a negative result. The next thing we have to do is we have to figure out the data that's coming in. Was the inclusion and exclusion criteria appropriate? And I'll talk a lot more about this later, but this is probably one of the most important things about looking at these studies, because we make sure we have proper information going into the study to begin with. And then were the studies actually valid, to make sure that we actually have information we can generalize out once we combine them all. And then were the studies actually similar to one another, or are we just trying to hodgepodge them together and then use fancy statistics to make them make sense? And the last thing that we have to overarch when we look at the entire thing is how much of a bias was impacted to this. And this is going to be bias on individual studies and bias of the meta-analysis itself as well. So ultimately it comes down to three main things. Are the results valid, or are the results valid? What are the results, and will they help me care for my patients in the future? And remember, overall, peer review does not equal validity. And so even though all these published articles are peer reviewed, it doesn't actually mean that they're valid. And you see this all the time where 2 years down the road, they go back and say, actually, this was not a very valid article, and we're going to take it off the market, if you will. Anyway, and so for this article, it essentially is evaluating how much exercise improves different aspects of patients that have hip and knee osteoarthritis. And they looked at four main things: quality of life, pain, function, and performance. And so when they're looking at putting this together, the first thing you have to do is figure out, where am I going to get my sources from? Where am I going to get the actual journal articles from? And then how am I going to choose from the millions that are out there? And so what they did is they started by doing a systematic review from these electronic databases. And so they went through the main ones that you can see here, and several others that I did not feel the need to put in here. And they looked through together all the randomized controlled trials in any language they could find, which is an important aspect, because you'll find that many of these articles will only search in the English language out of necessity sometimes, out of time, and ability in general. For this paper, they said that the RCTs must have some sort of exercise intervention that compared to a non-exercise intervention. And they used two different researchers that were independent of one another to do the same process, all on their own for the entire thing. And then if any time there was a discrepancy, they had a third independent researcher to be the tiebreaker. So going forward as well, the other inclusion criteria after they actually looked to select the articles, they need to figure out which inclusion criteria they needed to do in order to put it down into the next stage of their selection process. And so they looked for the hip and knee osteoarthritis that we were talking about before, but they want to make sure there was no surgical intervention, trying to take out some bias from that aspect. They only wanted to test exercise. They didn't want to use pharmacologic methods. And then they compared it to a usual group of usual care. Usual care for this paper meant that they had follow-up with their physician, they had routine exercise, or they're on a waiting list for some other management, such as a surgical intervention, but it did not already have happened to them already. Then they looked at these. They want to make sure these outcomes are actually reported in each individual study. If it didn't have one of these outcomes, then they couldn't compare it to the rest. And so by using these four main, albeit pretty standard outcomes for patients with osteoarthritis, it allows them to be able to generalize them and compare them to one another, which is important when we do the statistical analysis later. And they reported that they used the Baujat plot to ensure that the overall heterogeneity of the participants was low. And so what they did is they created this plot that you kind of see over here. This is not the plot from the study. They did not publish their plot. And so what I'm using instead is a surrogate that I pulled from this resource down here. But it's essentially the same thing. If you look over here on our y-axis, it has an influence on the overall result. Basically, how much is this going to impact our individual? Little interjection from the crowd. Anyway, here we have our contribution to the overall heterogeneity of our study, which is an important thing to kind of look at, because we want to make sure that our population is at least homogeneous enough to be able to compare to one another without having too many outliers in their overall. And that's what the Baujat plot looks at. And so as you can see in this example here, we have a collection of them down here in the left-hand corner, which is pretty common. If you have a similar sort of participants found in similar sort of studies, then what you'll have happen is they'll kind of cluster down here in the lower left. If you have some outliers, then you will see them over here, kind of out here. And a lot of times what they'll do is they will start to call out these outliers until they get them down into this left lower box here, which is standard. So this contribution, if it's under 5, is typically pretty good. You can use another score as well. You can use the I-squared score, which has a statistical function which you can run. And their cutoff here was looking for less than 30% to be able to ensure that they had an homogeneous enough population. Once they did this calling process, they ended up with 77 of 217 RCTs. And just to kind of go through their process a little more, they included their flow chart, which is here. And you can see how much information when someone has to go through these articles of what they have to start out with. So when they just did their search for mesh terms, which is included in their appendix, and there's like 50. Alrighty, so for our standardization, they will look here. The standardization allows that for different studies to be able to be compared to one another. And so you can imagine after 77 different RCTs that you will have a lot of changes or a lot of differences between how they report their data and how their data is intervaled. And so they went through a lot of different ways to try to put this together, which has its pros and cons when you start to think about it. And so initially they started by scaling with the most comprehensively reported or highest importance study. And what they did here is they used the studies done by Franson and Renault. And they have done like prior meta-analysis on osteoarthritis. And they kind of grouped in kind of what they thought the highest importance was. And that's what they used here. And then whenever possible, they use the objective performance, things that is really easily to be compared between different studies, such as steps walked, amount of steps gone, that sort of thing. If that wasn't included and there was things like power or strength, then they even made sure to define these a priori as well by doing knee extension followed by knee flexion followed by hip AB abduction, so on and so forth, to make sure that they really delineated this before they even started to reduce any sort of bias on that standpoint. And then they had multiple different time points that were reported, and so they kind of grouped them into subgroups of like 1, 3, and 6 month intervals. And this really helped to assist with them being able to go through and do subgroup analysis later. But for their study, they ended up doing a major endpoint of 8 weeks, which also happened to be the most common thing that they did as well. And then the less commonly reported exercise were included. If at all possible. So if they found something that like Tai Chi, then they would include that in the study, even though it wasn't, because it just wasn't reported very often, to try to give some more heterogeneity to the types of exercise applied to each study and for the overall result. And so as we kind of go through this, they also talked about how they did a bias risk assessment of each study as well. And to do this, they did a modified Cochrane risk assessment tool, looking at randomization, concealment, blinding, handling of the missing data. And so here is an example of a Cochrane risk bias assessment tool that you can see down here in my box. And essentially, this kind of gives you a graphical appearance to be able to see whether or not they have these issues. You can see times they have the green plus here, it tells us that that was reported and they did include it. If they have the red minus and they did not include it. And then some studies just did not mention whether they did or did not. And so in this case, you would have to give them a question mark. This is not the one from this study. I have that on the next slide, but I wanted to make sure you kind of understood the process beforehand because the next slide is pretty busy. It's a pretty busy table. Anyway, so kind of looking at this, you can see here we're blinded participants. This is all negative from everything because they did not blind the participants. But in some studies, you can see here that they blinded the outcome assessment or the assessor of that study. So then if you look here, you can see it's a pretty busy table, but they're doing the same thing of the table without the fancy color-coded manner to be able to look at everything. And so the thing I really want you to look at here is that for physician blind, patient blind, and assessor blind, you can see that neither the patient nor the physician were blinded in any of these studies here. Some of them say unclear, but typically if they're going to blind something, they're going to have that pretty forefront in their study. Though most of the studies here made the assessor blind. So this can be an important factor to try to think about too when you're looking at these studies, is to see whether they have that bias in there already. Because if you aren't blinding the physician or the patient, then there's always a chance you can have an effect bias or recency bias or any number of different things that could be accounted for by having neither one of them blinded. The authors of this study said that, you know what, it's okay. We don't have either one of them blinded, but we have the assessor blinded in most of them, which is probably good enough. And they use that argument. And looking at how the majority of their studies didn't have a physician or patient blind, I guess you could say that that's okay. But we can talk more about that later to decide whether that's a main factor that we need to worry about when deciding whether to listen to the effects of the study or the reports of the study. So when they finally got through and they included all the different studies and they boiled down to their individual participants, you can see that they had a number of different aspects here. And they're all pretty homogeneous in terms of the participants, which is in contrast to the heterogeneity of the outcomes or the effects looked at exercise on the patients. And that can have positive or minuses as well. It's really good to have a homogeneous patient population, because then if all the patients are basically the same from all the studies, then we know that we can combine the studies and compare them amongst each other pretty easily because they all have a similar patient population. And then you know that if this was one big study that included all these 6,500 participants, then it probably would have worked out and their statistics would have remained, null in the fact that you're not biased for one way or the other. Some things that were significant though was that they had a greater number of females and they had a lot more knees included in those trials than they did for hip. And so when looking at this study, we might need to consider the fact that the knee itself is overreported compared to the hip, and there's a statistical significant difference between the two of them that may play a role if we have a patient come in with hip osteoarthritis versus a patient has knee osteoarthritis. And so even though they included both of them in the title of the study and in the discussion, we might need to consider them differently on our own. The next thing that we look at is to look at the forest plot of these studies. And this looks at how similar the results are from the study to study. And I like to include the first one here, even though they include it in the appendix and not in the actual study, just because it was the easier one to look at. This forest plot is looking specifically at the quality of life that each of the studies reported for their patients' lives. And so when this happens, you can see a number of different things here. Each of the studies are listed here, and they each have a error bar associated with them, which represents the confidence interval. And they also have a gray box around it. And this gray box represents the weight of the study. The things that bring into weight is basically the same things you think of when you think of power for your study. And that's going to be looking at greater population sample size, and also looking at smaller confidence intervals that were reported in the study. And typically those things come hand in hand. And so you can see here that we have a 0 mark here and a negative standard deviation and a positive standard deviation here on the x-axis. And when we're looking at these studies, we try to say, okay, so our study here from whatever this thing, I can't read it because of the Zoom. But if we look at the one from O'Reilly here at the very top, we can see that our confidence interval crosses the 0 line. And you can also see that described over here from negative 0.11 to positive 0.47. Anytime we see that, we have to be conscious of the fact that the reports of that study itself said, we're not entirely sure what's going on. Either the effect that we looked at in this study made quality of life worse by 11%, or it made it better by 47%. Anytime you have a confidence interval that goes over 0, though, we have to know that it's not statistically significant, at least not in the terms that we're used to thinking of it, by rejecting the null hypothesis of having a p less than 0.05. However, when we can combine each of the different studies and combine all the different participants together, sometimes you can get a different result. And so that's what the forest plot helps us to look at. Not only does it give us a visual test for seeing how heterogeneous the studies are, but also kind of gives us an idea of where the results are going. If you come down here to the very bottom, you'll see a triangle. And this is a standard thing that you'll see in forest plots that kind of tell us where the mean effect of all the studies gets to for our quality of life. And so according to their forest plot here and their statistical analysis, it said that quality of life was improved by this amount here. And then you can come down here. It'll also give you the I-squared. Remember, the I-squared is what I mentioned earlier that helped us show of what the heterogeneity is. And it said that it was 36.4%. Just to give you a reference for the I-squared, if it has anywhere from 0 to 25%, you think mild heterogeneity between the groups. Anywhere around 50%, there's going to be moderate. And then 75% or greater, you're going to think of significant heterogeneity in the group. And so for quality of life here, the overall studies heterogeneity was pretty mild, which is good. So we can think, alrighty, they're pretty similar to one another. And it said that it gave us a benefit here overall when looking at all the studies. Maybe there is a benefit here that we can see. Alrighty. One of the things we have to be careful of anytime we have these studies is that we have the publication bias to worry about. And essentially what that means is that, like I mentioned before, anytime we publish a paper, we're more inclined to publish it, especially here in the American Western Society, to publish it if it has positive results. And so there's pros and cons for both of that. But what essentially does is that it means that the overall effect we see here is probably greater than what it really is, because all the negative studies, which would have their bars on this side of things, were not included. They weren't published, so we can't put the data in here. One way to get that data would be to go ahead and contact leaders in the field and say, what studies have you done already that you didn't publish because they had negative results? In that case, you can include that data into your forest plot here to get a more accurate sense. Previous studies that have looked at the publication bias indicate that it could be as great as 12% effect that increases everything. So it's something to just keep in the back of your mind. This forest plot is the one they did for pain. It's a lot more complicated with busier stuff going on here, so I didn't show it to you first. But essentially what I wanted to show you here is that even though it still shows that we have a positive result down here, it shows that our I-squared is now 75%, right? And so what I just mentioned is that anytime we get to 75% or higher or around that range, we're looking at a lot greater heterogeneity between the different studies, which may mean that it's harder to clump them together and bring them all together at the end. So even though they're making the argument that, these are all really similar studies, we're just looking at exercise overall, it helps with pain. We have to think to ourselves, well, maybe it doesn't help with pain as much, or maybe it's only certain exercises within that group that's actually helping pain and not all of them that we're thinking about. So then all the stuff I've gone through is really the most important part of these meta-analysis and systemic review articles. And bringing in the data is the most important thing. Because if you get garbage data in, you're going to get garbage data out no matter what statistical analysis you use. So it's really easy to get the results at the end of the article. It's all the stuff at the beginning that really matters to whether you care about it, which is different from like a randomized control trial in which you're really looking to see what statistical differences they use to make that data. And then here it's less of that because we're already trusting the authors of this article to have gone through all those randomized control trials and then distill it down into one big thing for me to be able to use for my practice. In this case, they said that relative to usual care, which is basically just like normal physical therapy or whatever, exercise had a benefit relief or moderate benefit for pain and for function, and then only a mild benefit for quality of life. Okay, and so it shows your effect size here, the ES, kind of gives you that general amount, followed by your confidence intervals right here next to it. And so I want you to keep in mind what I just talked about with the effect size being greater for pain relief here. But remember, when we went back to the forest plot, it actually had a lot greater heterogeneity to it. And so even though it has a greater effect size, you have to remember that there was a greater chance that there could be bias or error in that setting. Whereas the mild benefit you see for quality of life, you see down here, could potentially have a truer effect because we have less chance of error bias according to our forest plot. Alrighty. And then it went on to say that they peaked at 8 weeks and then decreased over time, so that the longer studies that were done had a less improvement overall for the different things they looked for. And there was more benefit for women aged over, or people aged less than 60, women, people with knee osteoarthritis, and people not waiting for surgery. And this was all done through the subgroup analysis. And so then when you look at the subgroup analysis here, it's another thing that you have to critically consider as well. And so the interesting thing that the authors decided to do in this paper is that they did a 0.05 p-value for the entire paper itself until they got to the subgroup analysis. And they decided, you know what, it's going to be significant when p is less than 0.1. Which is kind of a surprising thing for them to be able to do. And they never really carefully explained it. They just said, you know what, it's probably good enough given all things. And they didn't really specify whether they chose that before designing the study or if it was afterwards, which makes me a little suspect. So when you look at it here, you can see that the things I bolded are the things that they thought were statistically significant for osteoarthritis, but it has a greater p-value. If we use our normal cutoff of 0.05, the only things that really matter are going to be our knee joint, and if we come up here to our age as well. And so these are things to keep in mind as well. And the last thing I wanted to show is that they also showed the effect going down of exercise at various times, going through for pain, for function, performance, and quality of life. But if you also look at the number of trials for each one, oftentimes they have much fewer trials that have the longer durations, which may also play an impact into the overall outcome and how we interpret the data. Alrighty, so I wanted to ask you guys, hopefully we have cleaned out all of the other people from the thing, but I want some people to tell me what strengths they saw from the study if they read it. And if no one has any strengths, or that's fine too. But I thought I'd open up to y'all first so we can kind of make it into a real journal club a little bit.
All right, y'all can unmute yourselves, by the way. So you're just asking for strengths of the overall paper itself?
Yeah, so I kind of mentioned strengths and weaknesses as I was going through. You're welcome to bring those up again if you want to, or if you had any other thoughts reading the article, feel free to bring them up. I'll point out some that I thought were poignant going through, but I wanted to see any thoughts y'all had first.
I think one strength, I don't know if you mentioned specifically, but I just noticed they used all the databases with all languages. So I think that's a good idea of going through almost every bit of data. And it seemed like they had 200 something randomized control studies that they examined. And it seemed like they did a good job of filtering out relevant ones. I don't know how much of a strength that is.
No, I totally agree. And that's exactly, it's a huge strength, especially for these articles. I didn't mention the differences between a systematic review and a meta-analysis, but a systematic review basically takes all the studies that are similar in nature, and then they combine the information together and then present the information just kind of qualitatively. The meta-analysis portion of it actually takes the participants from each one of the studies and they break it down and do statistical analysis to try to combine them into one large population group. Does anyone else have any other strengths they want to mention?
I thought it was interesting that they included those studies that, I'm sorry, my voice is a wreck right now. I thought it was interesting they included those studies that had the physician and the patient not being blinded, but the assessor was blinded. Personally, I think that is an okay model, but I am curious what you thought about that too.
Yeah, no, I completely agree. I think that it is an okay model too. And I try to present this paper very objectively to y'all without giving you any sort of ideas on what I thought of it. But yeah, sometimes this makes a big difference. Take surgery, for example. You can't blind the surgeon doing the procedure. So that's an impossibility. For doing OMM, you can't blind the person performing the OMM to the patient while you're doing it. And so some circumstances, it's impossible to be able to blind it. Now, how would you blind a patient to the fact that they're doing exercise or not doing exercise? Right? It's pretty much impossible, right? We can try to lie to the patient and say, oh, what you're doing here is exercise when it's really not. But most people have an understanding of what exercise is, right? And so, yeah, it's really hard to blind that. But it's just a point that I brought up to make sure you keep in mind when you're looking at these things. What other thoughts do you have?
Maybe this is a weakness, but just similar to what you're just sort of going off of is blinding based on exercise is reporting on pain and quality of life. What if these people didn't even have osteoarthritis and they did these same exercises? How would their parameters change? As just a general person who went from not exercising to exercising, how much is specifically just exercise in general?
Yeah, exactly. Right. I think these are all really good thoughts. And so I'll kind of take you through some of the ones that I thought were important. If I can bring it up here. And so they used independent viewers for the article, which is really important because sometimes you can have just one person do it all, and then that brings in a lot of bias by themselves. And they include a lot of studies that had homogeneous patient population. And then the patient population, even though it was really homogeneous, was still really broad to generalize out. And so anytime we're looking at these things, we want the participants within the studies to actually be able to be generalizable to the patient that I have come into my clinic next week. And so these are important things to think about. And they also did consider the risk of biases they're going through it. They brought it up multiple times, and they brought up several things that they tried to like mitigate it, right? They used our forest plot, they used the Bourgeat plot to try to help do it. And I have a funnel plot coming up later on as well to kind of talk a little bit more about that. And then they also did appropriate data abstraction as well to really make sure they tried to standardize the data between the studies to make sure it fit nicely, and then did in a very systematic way to ensure that they didn't have any other bias from that. All right, so we kind of talked a little bit about limitations. What other limitations did you guys think of?
One of the limitations that I thought that you had previously mentioned, I don't know how much, I am curious about how much of a limitation you thought this was, but the heterogeneity percentage being about 36% as opposed to 25%. I mean, it's understandable that you had that much heterogeneity with the amount of data that they were, and the volume of studies that they looked at across. But I don't know if that truly impacted it. And then I don't know that this is a limitation, but more so just kind of a disappointment. I was a little disappointed in the quality of life findings that didn't quite as improve as much as they wanted. And I'm not quite sure if that's a limitation or just a disappointment in the data that was collected, but
no, those are very good thoughts. I totally agree. And so when looking at the heterogeneity of these studies, like I kind of alluded to before, it's important to try to think about these things and the fact that, heterogeneity means that it's harder to make it externally valid as we go through these sorts of things. But at the same time, we also are looking at a very broad thing. They just said exercise, right? They said exercise from walking to going on a treadmill to weightlifting to Tai Chi to yoga. They included all of it. And so I think just by doing that factor alone, they're going to increase a lot of heterogeneity into the study. And you could argue either way, whether that's a good thing or a bad thing. One thing you could look at is like, okay, if I simply tell my patient, go out and exercise, do what you want to do, if you believe the results of the study here, then maybe it'll do some good for them, at least up to 8 weeks, right? And then it'll go down slowly over time with that. That being said, you could also think about it the same way as like, well, I'm glad the study is out there. It tells me exercise does something, but it doesn't really tell me what the best exercise that I need to recommend to my patients is, right? And that's part where the heterogeneity comes in. And they say to me, what's better, doc? Do I go ahead and do yoga, or do I run on a treadmill to take care of this? And you can say, well, you have to look at the research. You can't use this research article itself. And so you have to remember all these different pieces when you're trying to counsel your patients and deciding whether or not you want to include this article in your bank of information. Any other limitations people thought of?
A quick general question to what you just said, as far as applying this to your patient population. Some of my confusion is just being a med student is when you read something like this as a resident or practicing physician, what's your next step? Now, are you going to go start Googling or searching for articles that specify the exact exercise to do, or just kind of test it out yourself? Or I guess it probably depends. But what would your personal opinion be on that?
Yeah, so that's a really good thought. And so part of it is just going to be your clinical acumen as you go along. And it's also going to be what your patient desires too. And so you can say, this is the best thing for you. I want you to go out and I want you to do hot yoga with only instructors that have been practicing for 15 years. That's on a 5mm yoga mat, right? And so you tell this to the patient, and the patient's like, wow, that sounds really expensive. I work, a blue collar job, and I'm going to have a really hard time being able to afford that. And I was like, well, that's too bad. If you want your arthritis to get better, you have to invest in your future. And so you can see, I'm using a very dramatic example, but you have to bring a lot of different factors into play when you're trying to think about these things. And yeah, it makes it really challenging to do evidence-based medicine. And I think it's really easy to fall into the trap of saying, oh, I read the abstract of this article. This is the results it told me. I think I'm going to do that because it gives me a good enough answer for what I want to hear right now. And that's a dangerous trap to fall into. And so when you're thinking about these things, yeah, maybe my patient tells me, you know what, I really like to run, but every time I run with my arthritis in my knees, it hurts me. I'm okay to keep running through the pain. Do I continue doing this, hopefully with it getting better or mitigating the disease progression, or do I go to something else? And so when you have a specific question like that, that's when I would encourage you to go into the research and try to bring up articles or research studies that have looked at that question already, okay? If you are unable to do that, then you're going to have to fall back on what your mentors and your trainees have done before you and say, you know what, I've done this for my patients in the past. It's worked well for me. I don't have any research behind it, but I do have 20 years. There is a certain amount of inherent bias associated with that, but it is another option that you can do as you're going through it. All right, we're getting more into discussion stuff, so I'm just going to finish going through these limitations, and we can discuss anything else about the article we want to. And so when I was looking at this article, when I saw this here, it was basically saying that they didn't attempt to investigate the unpublished research or even do a thorough examination of references. And this is something that is often cited to be an important part of doing any thorough job for one of these types of studies, is to reach out to other publishers out there, or researchers, and say, what have you not published? I've already mentioned all that, but the other thing we need to do is go through and actually look at the references of each one of those papers that we include in the study and make sure there's nothing else that we're missing that's going to be important to it. So not all of the references that are on there could include studies that were around before digitation happened, which may be an important thing we want to include into our study. Maybe they looked at these things really in depth, back in the 60s, but they're not digitized, so they don't have the same mesh terms anymore. But the researchers that have been around since the 60s know about the articles and include them in their references. And so making sure to include those is going to be an important aspect. And then they attempted to use a statistical analysis show lack of publication bias. And I felt like that was them trying to explain away some of their, you can call laziness or inability to do whatever the reasonings was. They didn't include it, and they tried to explain it away with statistics instead. And they made no mention of obtaining patient level data. And so what that means is that they go through and they actually contact each one of the researchers and say, I want your original raw data so I can include that in my research study. When they're able to do that, then it gets rid of all the bias that they include in their statistical analysis initially. And it goes right down to the raw data that was collected. And they assume that the non-blinded physician patients was acceptable. I think it's a limitation overall, just because the physicians weren't blinded. But I kind of explained, I don't think it's as big of an issue as maybe for some other studies. The last thing I want to try to talk about is that there's these things called funnel plots that they also include in here as well. And this is looking at the overall amount of bias that's included within the studies. And so essentially what these crazy things look at is it's saying that the basis of bias is that studies will give random assessments of the same unbiased mean value. Essentially, that's just a lot of jargon to try to say that what should happen is that as we have lower quality studies with fewer participants, we should accumulate down here at the bottom, and the standard effect size here, or the standard error of the effect size over here is going to be less. As we start getting to a higher studies that have a higher effect size because they have more participants, they're better controlled, all those sorts of things, then they're going to start to center around what the actual mean of the difference is, or what the actual impact is of that study. And so if we look here at the top, this will be like our best studies. We'll cluster around where it really should be, and all the worst studies should be down here. If you start to see bias presenting, then you'll start to see outliers on one side of where the effect mean is, or on less, or on the better side, right? And then oftentimes it'll cluster down at the bottom as well. So you'll see here that we have clusters around the outside edges. And so this kind of gives you a sense that there may be some extra bias in these studies here, because even though they have a lower effect size down here, or the standard or the effect size is lower, they're still saying, you know, our study shows that the effect size overall, like our study showed that doing yoga was the most important. Look how much better it is for us over here than all the ones over here. And so by analyzing them all together, it kind of gives us an idea. Now, when you look at the funnel plot, it gives you these arrows here that show everything should basically be included in this umbrella. And you can do further statistical analysis. And that's what this study did, is saying that even though we have these ones out here, we still think that it's okay and we don't have that much bias, because we did the Eggers test on it, which showed that it had a p-value of less than p0.005 for all of these besides quality of life. Okay, and that's basically what we're looking at here, and that's how they're attempting to explain the bias and what a funnel plot is. All right. So just for the discussion, what do you guys think? Do you agree or do you not agree with the results of the study?
I think I think the claim is fair to say that exercise does have an effect on patients when it comes to the areas of, I wouldn't say quality of life, but I would say with pain, and then of course the other two that I can't remember, pain reduction over 8 weeks, especially considering how broad the exercise categories were, in terms of the movements that the patients were doing, what they were tracking and everything. And I would maybe say for the knee specifically, as opposed to knees and hips, I think that would be where I agree with those points that the study made. I think the conclusion in the abstract said it just lumped everything together and said it's all 4 factors were improved over time, which they technically kind of were based on the way that they did crunch their numbers, and that it was for knees and hips. I think that's going a little far. But yeah, I think it's fair to explore exercise for 8 weeks for sure, especially with your patients with knee pain for osteoarthritis. At least that's my 2 cents.
No, I think it's very good dissent. What about any dissenters?
I'm sorry?
Any dissenters out there? Anyone that didn't agree with the author's conclusions of the study?
I won't say that I disagree with the study. I think that if someone comes in and is having knee pain, it's like, absolutely, this study reinforces the idea like, hey, it would probably be a good idea to discuss exercise with them. But I do think, this kind of harkens back to like limitations of the study and how it, spoke to it's not as effective for like people who are older. Like, so maybe I wouldn't agree with promoting this with someone who like may not have the means to have access to like safe exercise. Like, do they have a fall risk, or are they elderly? Like, even if they do have knee pain, would it be worth advocating for that, or hip pain? Like, would it be worth advocating for them to like improve that with doing the exercise, which isn't so much like dissenting from the study, but just an instance where I like, despite the outcome of the study, wouldn't like encourage exercise with a patient.
Awesome. Yeah, I think you guys are bringing up really good points. And it's kind of the overall point I wanted to make with this journal club is that we don't have to take the study for all or nothing, right? Just like Nicholas said and Tiffany said that, we have positive aspects of the study, but maybe I don't believe all of it quite yet. Maybe I want to see further research that further elucidates these factors before I'm a total buy-in on what's going on. And then their p-value of 0.1 in the subgroup analysis. I kind of already talked about that and run out of time. I think that's a little sketchy in general, but I think I'm getting some head nods. It's probably some agreement there too.
I forgot to bring that up when you asked about limitations. That was the disappointment. I was also disappointed in quality of life, but that was the one where I was like, oh guys, come on.
I know. Yeah, I felt the same way. Anyway, what are your thoughts about why the effect of exercise decreased over
time? Well, I can take the low-hanging fruit and just say what they said in the paper, kind of. I think they mentioned just adherence, lifestyle factors playing in, and just people not doing their exercise regimens as well as they were to start with. I'm sure there's multiple other factors, but that's one that they did mention.
I also think a possibility might be when you first start an exercise regimen and you're moving more than you were before, like you're noticing improvement, and then you may be at a point where you're improved from before, but you are at, a plateau as far as like continued improvement. So it's like the effect of the exercise from initial onset hasn't decreased, but just the continued effects of exercise because of like bodily limitation or age or for whatever reason just is no longer causing continued increased improvement.
Exactly. Yeah, those are all really good thoughts. And then, just with the nature of osteoarthritis in general, we have a certain disease progression that is really hard to mitigate overall. We know that from other research that, things like exercise does not typically induce osteoarthritis. There's certain circumstances in which it does, like rock climbing will almost always induce osteoarthritis within the finger joints by the time you're at age of 40 if you're a routine rock climber. But for the most part, like it doesn't increase it. But the other side has shown that even though you still have pain after, it doesn't propagate the disease process faster, but it's still going to continue to progress on with how the disease process happens. And so it's going to always get worse. You can't stop it from happening to get worse. And so sometimes you have to think about, well, the disease still gets worse, but we don't know if the exercise mitigated that at all going through. And then kind of another low-hanging fruit, why do you think that our younger patients expected better results?
Perhaps just they had less degeneration and chronic change from the arthritis in the first place.
Yeah, and I agree with that too. I think that's kind of the main thing that I think of as well, is that our younger patients are typically going to have a less amount of osteoarthritis. We also have to think about age-related sarcopenia as well. And so our muscle mass typically peaks at the age of 30 and then slowly declines after that. And we know that one of the main things that helps offload our joints is going to be muscle mass itself. And so younger patients, when they start to exercise, are going to have a more robust response to muscle hypertrophy and to growth than an elderly patient will. And so they're probably going to receive more of a benefit from that aspect of offloading of the joint onto the muscular system, whereas the elder patient's going to have more of a onloading onto the skeletal system. And then you guys already mentioned a lot of this already. Will your practice as a physician change? I think you guys mentioned, yeah, it will change a little bit, but maybe not in all aspects of what they're talking about. And I have to agree. I think that trying to tell my patients, especially with knee osteoarthritis, if they're younger, try to work on exercise, especially give it a try for 8 weeks and see how much it helps you before doing other interventions. It's always a great place to start. There's few side effects associated with exercise. It's typically pretty cheap to exercise if you live within a neighborhood that's safe to exercise outside. And then you can do a variety of different things. And most people can find something that they enjoy within the realm of exercise, whether it's running or yoga or tennis or even going to the pool and just trying to walk around. All righty. What are the thoughts that anyone wanted to say before we finish here?
I just wanted to add something, and I apologize if you'd mentioned this, but what you just mentioned about like accessibility to exercising areas, was that talked about in this study at all? Or like, was that conveyed? Like, were some of these patients able to, like, was it clear that they had an accessible place to go exercise, like a park, or could it have been a lower like socioeconomic area where maybe that is something difficult to, obtain?
Yeah, absolutely. I completely agree with that. They didn't mention it in this study at all. But you're right. It is something that we have to think about with our patients. Just like we have patients that live in a food desert, we also have patients that live in an exercise desert as well. For many of us, I'm sure it's probably pretty easy to be able to go outside and just go for a quick run or jog and do what we need to do. And then if not, then we probably have the ability to pay a few dollars a month and do some sort of subscription to be able to work out in our living room. Okay. This is not going to be the case for everyone. And so it's going to be harder for someone in that circumstance. Whether or not they mention those things in each individual randomized control trial, I don't know, because I haven't gone through all 77 of them. But it is something that we have to consider for our patients going forward. We can't just blanket say, go outside and run when they don't have the ability to do so.
Well, the other thing too is there's still lots of options that are like, assuming that people are able to get internet access, and most people with phones and data plans and whatnot have access to YouTube, which has a plethora of yogis who do stuff on there for free. There's rowing stuff if you have a rower. There's like walking stuff in your living room. I'm sure you could get access to like Jane Fonda videos, I'm sure, on there or anything like that, just to like do in your living room. I haven't done any of those yet, but they're on my list. Yeah, like there are options. I think it is interesting that you mentioned exercise desert, and that does make sense to me. But it also, like, if patients do have like a roof over their head and like space to work around, you can even like work up a sweat in like a minimal amount of area. And so if we're talking about just getting your heart rate up, there are ways to do that. If we're talking about specific like range of motion exercises for knees and hips, there are ways to modify exercises. Like if you can find like a step stool in your house, you can step up on the step and go down, and like there's ways to get around it and work with patients. It's just a matter of kind of thinking creatively, I guess.
No, yeah, and that's very true. There is a lot of stuff on YouTube that you can do. And I was thinking about that as I was mentioning this earlier. But one of the things I was thinking about is that the health literacy of a lot of patients can be low, especially if they're in this circumstance. And one of the examples I'll bring up is just a patient I had maybe a month ago when they asked me, what do the lungs do? And so you really have to kind of broaden your experience of what your patients do or do not know. A lot of patients may or not be willing to state those limitations that they have as well. And so we have to be careful with saying like, oh, modify these exercises when they will have no idea. They'll go on YouTube and then the person on YouTube tells them to roll out a yoga mat. And they're like, well, I have a pretty crowded living room. I don't really have that much space. I can't do what they're doing on the screen. Which is why physical therapy is great, because they will work with them individually and help them say like, this is how you can do this exercise. And these are ways that we can modify what you're doing at home to be effective. But yeah, they can do it. I think it is difficult for them to be able to do. I'm not disagreeing with you at all. I'm just saying that we have to try to think about like lots of different aspects of it. Any other thoughts, anyone?
The general question outside of the study. So what do you recommend to us med students that want to get more into reading research? I learned a ton in this about how to pick it apart, and now I feel like I'm being more comfortable just reading more research. But now the struggle is, what do I read? You talked about that a little bit at the beginning about just the scope of practice. But how do I go find a Sentinel article to start out with?
That's the question,
There's
right?
so much.
There's so much information out there, and it can be an overload. So PM&R as a whole, I feel, has done a terrible job at kind of collecting landmark articles within the field for things like TBI or spinal cord or musculoskeletal medicine. Other specialties like neurosurgery or OB-GYN, I feel like have done a much better job. AAP, I believe, is the one that has a collection out there, but their collection was created almost 10 years ago and it hasn't been updated since. And so the landmark studies may not be landmark studies anymore. But that brings up my next point, is that trying to listen to your colleges, AOC, PM&R, AAP, AAP, to help direct you going forward is one place to start. Your mentors in the field, your attendings, asking them which articles they believe in are good places to start. And then even if those aren't options or that's not working out for you, then subscribing in a journal that you believe in, such as like the Purple Journal for AAP&R, I think is a really good source. And then from there, just trying to answer specific questions by going on to your favorite site like PubMed or Google Scholar, and then going from there to see which articles they referenced in there going forward. And that's kind of my approach to be able to find new research in general. I think your other question was, how do I find out more about how to dive into research and what questions can I ask to critically think about these things? Part of it is just going to be repetition by reading articles. The other thing is going to be, there's research articles about research articles. And so they'll tell you how to critically analyze an RCT. Research.net or researchgate.net, I can't remember, also has a lot of good support on there as well regarding information about trials and how to critically analyze these things. And then whatever journal club you do in your residency program is to encourage yourself and your fellow residents going forward to challenge each other. And then if there's something inside the article that you don't understand, to go and look it up. And you'll find the resource out there that explains it.
Thank you.
All right,
Hi, Dr. Larsen.
go
I
ahead.
just put some questions in the chat.
Your question last, just because I want to be respectful of people's time, and we're already a few minutes over. But yeah, go ahead, Thomas.
Oh, yeah, we sent out a forum and just had a few questions. And I guess one of the most important things to ask at the moment is what should we know or study before we enter rotations?
Oh, okay. Yeah, anyone that wants to stay longer for this sort of talk is totally fine with me. Before you go into rotations, there's a number of different resources that are out there that you can use. There's the Pulmonar Pocketpedia textbook that people like. I'm trying to see if I have it on my bookshelf here. I think it's at my work. Anyway, that's an option that a lot of people like. It has a lot of concise information within it. Michigan State University has a medical student handout that is available freely on their website that has a lot of the outpatient, inpatient, like must know critical information on there that I think is super helpful. And that's basically all the information you really need to know before you start these rotations. You'll learn the rest of it as you kind of go through. And that's the whole point of the rotations, going through. I feel like that question segues slightly into what you really want to know is how do I succeed on these rotations to look good? More so than like, what do I need to know before I even get there, right? The rotation is there to teach you stuff, not you come in already knowing everything. And it's just working hard, working as a team, and being present at all times is going to be the best thing for you.
Awesome. Thank you.
Dr. Marc, thank you so much for joining us and for sharing with us your time and also creating a great learning environment, teaching environment, and a place where we could ask questions. Thank you.
You're welcome. Thanks for coming, guys. I appreciate the opportunity to come do this. Hopefully it was helpful for you all. And if you have any other questions, feel free to direct them through the research people, and then I'll be sure to answer them via email.
Yes, thank you. Thanks so much, everybody.
You're welcome.
Thank you all for coming.
All right, y'all. Have a great rest of your night.